Hi, this is Brian Kim. I want to share with you case number 122 in the Best Way to Do Cataract Surgery series. This is a 3+ dense lens and an incredible shrinking IFIS pupil. And so you're going to see mechanical fracturing techniques and how using lens disassembly with mechanical fracturing forces, not using aggressive ultrasonic energy or vacuum, and very carefully and methodically disassembling the lens using mechanical forces can really handle the incredible shrinking IFIS pupil situation. So I'm going to use a corneal marker, which will help me to center and size the rhexis. You can see this pupil is not too small, not too big. It's a little bit irregular in shape. I'm going to make a paracentesis incision first on the right side and then the left side, making sure I'm parallel to the iris plane, which creates a nice corneal shelf, which will allow me to achieve a self-sealing incision. This is intracameral lidocaine and then intracameral epinephrine. You can see as I'm pulsing the epinephrine, you can see the iris is wobbling a little bit. This is some dispersive viscoelastic, which further viscodilates the pupil. You can see how much it viscodilates. This is a little bit of a clue that this patient has a little bit of a floppy iris. And this is a triplanar corneal incision. I make a vertical groove, place the blade into the deep part of the groove tunnel, turn the eye towards me with the cannula, and then I enter. Go ahead and push a little bit more viscoelastic before I come out. And these are those Haldey-Perkar forceps. I'm going to go in with the teeth sideways. Gently puncture the center. I'm able to puncture. I pull down with the tear, grabbing the right side of the tear, making sure the tear is about the correct length, which mimics where I made the corneal mark to help me center and size the rhexis. These forceps really give me exquisite control, good chamber control, very little fluid egress, viscoelastic egress, and I'm able to do the rhexis without really having to pull centrally. Very controlled situation. Go ahead and finish off the rhexis. This is the Capsular hydrodissection technique. I place a cannula under the rhexis edge contra-incisionally, get a nice wave, decompress on the left side, sweeping under the rhexis edge on the left side, turning the cannula tip down on the right, and the lens spins. Irrigate the surface of the cornea, adjusting the sleeve, lifting the incision with a chopper, going in with irrigation off to minimize Descemet's trauma, removing the surface epinuclear material, placing the chopper on the rhexis edge contra-incisionally, pointing the phaco tip vertically subincisionally, bringing both instruments together, fracturing the lens completely in half, that's double chop, placing the chopper around the right heminucleus, pulling it centrally towards the phaco tip, crushing and dividing that right heminucleus, that's cross chop, using some vacuum to lift that first quadrant up, crushing the lens between the instruments, and then emulsifying the lens pieces. All of the action is with mechanical forces. There's no vacuum, there's no impaling of the lens, there's no grooving or sculpting. This is a very efficient way to crush the lens pieces between the two instruments. And so, this is a really, from an intuitive standpoint, it makes a whole lot of sense. You're just going to crush the lens between the two instruments. You don't need any vacuum, no ultrasonic energy. When you crush the lens pieces into smaller pieces, you have to use less ultrasonic energy. Less ultrasonic energy means less potential damage to the corneal endothelial cells, potentially clearer corneas. I turn the second heminucleus in front of me, placing the chopper around the lens piece, pulling it centrally towards the phaco tip, crushing the lens between the instruments, doing the same maneuver around the third quadrant, crushing and bisecting the lens, and then using successive efforts of crushing the lens between the instruments over and over again until the pieces are smaller, and then emulsifying the lens pieces. This is the reason why my CDE is consistently so low. People think CDE is overrated, but unless you do this technique and you actually see the post-op results, unfortunately, you don't quite understand what you're talking about. If you do these techniques and you really minimize ultrasonic energy, I have found consistently clearer corneas post-op day one, consistently happier patients with such a dramatic and a fast visual recovery after cataract surgery. And again, this is a 3+ dense lens. This is not a small cataract. And in Northwest Georgia, I see a lot of dense cataracts. And so This is really a tried and true technique. I've done this technique on mission trips, very dense cataracts all over the world. And this is a really battle-tested technique. And so I'm able to efficiently emulsify lens pieces very safely. And in this case, where there's IFIS potentially, it's very safe. So I'll go ahead and remove the epinuclear material here. And little by little, as I'm doing this case, you can see this is a very gentle case. You can see this pupil slowly trying to shrink. Very carefully removing the epinucleus, keeping the chopper deep to protect the posterior capsule. So carefully take the chopper out, push BSS in, take the phaco tip out, and I go in with the ironing handpiece. Go ahead and start to polish under the rhexis edge. Of course, since the pupil is already coming down, you just have to be mindful as you're polishing. You can't see underneath there. And you saw that I grabbed the iris just a little bit. Of course, that will also encourage the pupil to come down even more. So you just have to be mindful with that. You don't want to skip this step and not polish. You want to really give every patient a really nice clean bag and removing lens epithelial cells whenever possible. Polishing the posterior capsule as well. You can see there's a little bit of posterior capsule fibrosis here as well. So go ahead and pulse the subincisional capsular fornix with BSS. I'm going to be very careful when it's difficult to visualize a rhexis edge here with that cannula. Go ahead and fill the capsular bag with cohesive viscoelastic. Then I'm going to polish under the rhexis edge. Again, this is the original capsule sweep that I have. And you can see how blunt the sweeping side is. And so this is why, again, it's a smaller paddle. It's not angled as well as the other ones. You can see the iris is a little bit unstable here. I'm being very mindful to not allow the iris to prolapse as I go in with the injector. Carefully delivering the lens into the capsular bag, at least the leading edge. Quickly coming out and transitioning to the INA, activating irrigation, disengaging the haptics, making sure the haptics go within the bag, going underneath the optic, tilting it and rotating at 90 degrees, removing the viscoelastic from within the bag, and making sure both haptics are within the bag. Repositing the optic back into the bag. You can see the pupil just dramatically shrank here. So go ahead and switch to polish mode, polishing under the rhexis edge. This is essentially a blind maneuver, but because it's polish mode and it's low vacuum, it's safe. And switch to visco mode, removing all the viscoelastic from the anterior chamber, and then I'll hydrate my incision. So you can see this patient's pupil dramatically came down, but that, the last quarter of the case, you saw I did mechanical fracturing, double chop, cross chop, very carefully, systematically disassembled the lens using crushing forces. Again, if you use high vacuum, especially in situations where there's a smaller pupil, you might cause damage. And in general, I try to use as little ultrasonic energy as possible. Again, in my experience, by doing this technique, you're able to get around the lens a lot more efficiently. When you're doing horizontal chop, traditionally, you're just really scoring the top half of the lens. For dense lenses, you can't get all the way through. With vertical chop, you can't really chop soft lenses. So both of those have quite a lot of limitations. And then, of course, divide and conquer, you're having to use a lot of ultrasonic energy by grooving. There's some critics who say, oh, as long as you coat the cornea, it's fine. Well, the problem is you can't see viscoelastic. And so sometimes you think you're coated and you're not. And then you see the patient post-op and they have 2 to 3 plus or 4 plus corneal edema and folds. With this technique, you have consistently clear corneas with mechanical fracturing. And so I really think this is the best way to do cataract surgery. I hope this was helpful to you, and I thank you for your attention.